Hi, boys and girls. Endometrioma and surgery. This is a new talk, October year 24. I'm Dr. Puuja Arora, your study buddy and mentor from Just Mrcog. Again, as always, I try to simplify this talk for everyone. Let's start without wasting time. Endometriosis is a common hormonally driven inflammatory condition with a prevalence of 6 to 10% in women of reproductive age. So prevalence is 6 to 10%, and this is hormonally driven inflammatory condition. And these women may experience cyclical or a non-cyclical pain symptoms. 30 to 50% of women with endometriosis can present with subfertility. Important percentage, 30 to 50%, that is 3 to 5 out of 10 women may present with subfertility. Endometriosis is surgically subdivided into three different entities: peritoneal lesions, deep endometriosis, and ovarian endometriotic cyst, that is endometrioma. So, when we discuss endometriosis in surgical point of view, then we divide it into three parts: peritoneal lesions, deep endometriosis, ovarian endometriotic cyst, or endometriomas. Decision of surgery. Individualized reproductive plans for women with endometriomas and history of infertility. So, how we take a call for surgery? We make an individualized reproductive plan. A patient who has come with the history of endometriomas and has history of fertility. There are certain factors which we consider: patient's age, previous surgeries, size and laterality of endometriomas, means it's whether right, left, or both. Ovarian reserve tests such as anti-malarial hormone, which is a blood test, antral follicle count, which we check in ultrasound. The last is coexistent etiologies for subfertility. What are those? Tubal status and semen parameters. So when we decide about the surgery, we take these 5 factors in account. 2022 ASHRAE guidelines clearly says that when there is a clear indication for ART, then surgical treatment prior to ART is obsolete, unless to manage endometriotic associated pain or to improve accessibility to ovaries. Means a patient is for ART, we do not offer surgical treatment unless she is coming with intolerable, unbearable pain. And then we have to give her treatment for pain, or we have to increase the accessibility to ovaries. Only in that case, when there is already an indication of ART, will still offer surgery. Symptomatic patient with infertility, a patient who has pain, dysmenorrhea, and also having infertility. What all options we have for her as per this new talk? Surgical treatment may be beneficial both for endometriosis associated pain and infertility. So, symptomatic with infertility, surgical treatment is an option. And what is our aim in this patient for surgery? Excise all visible endometriotic lesions, normalize the pelvic anatomy to effectively manage the endometriosis associated pain. So, excise lesions and normalizing pelvic anatomy. But conservative techniques to treat endometrioma. This is a very important point. symptomatic patient with infertility, conservative techniques to treat endometrioma, though excising lesions and normalizing pelvic anatomy because that helps in pain. Operative laparoscopy can be considered for the management of endometrioma associated infertility. It's not always that we offer conservative. At times, we may consider operative laparoscopy as it increases the likelihood of spontaneous conception. So, what is the advantage of operative laparoscopy in symptomatic patient? It increases the likelihood of a spontaneous conception, means after the surgery for endometriosis or endometrioma rather specifically, or to be very specific, it increases the chance of natural conception, though it doesn't increase ART success rate. So that's the reason where you find, as we have discussed in previous slide, where we find a clear-cut indication for ART, we always offer ART direct and we always ignore or avoid surgery. So it doesn't increase any success rate in ART and it may be detrimental for ART. What are the reasons which cause detrimental effect of laparoscopic or any surgical treatment in a patient who is willing for fertility or who is willing to have conception and symptomatic as well? So what are the causes what are the reasons which cause detrimental effect post-surgery? Surgery and need for post-operative recovery can delay the start of IVF treatment. Logical. It was any collateral damage to ovarian cortex or vasculature can compromise the ovarian reserve. This we are aware of very much. And when we discuss the task of big ovarian cyst in young women, we always discuss this, that post-surgery or during surgery, there is a risk of collateral damage to ovarian cortex and the vasculature, which can compromise ovarian reserve, leading to fewer oocytes and requirement for higher dose of gonadotrophins. Logical, we know this very well. Conversely, patients should be counseled that size of endometrioma is an important factor that can affect the response to ovarian stimulation in affected gonads. Rather, we should counsel against the surgery by mentioning that size of endometrioma is very important for the response to ovarian stimulation. Potential reduction in responsiveness to gonadotrophin following ovarian cystectomy is more or less same. Ovarian stimulation to affected gonads or potential reduction in responsiveness to gonadotrophins following ovarian cystectomy. So that's the reason where there is direct ART, we do not offer any surgery. Symptomatic patient with future fertility. As of now, we were discussing patient with fertility, means she wants to conceive now. Now the next is symptomatic patient with future fertility concern, means she has symptoms but she wants to conceive in future. In that case, surgical and medical treatment of ovarian endometriosis. Though in symptomatic with fertility concern, it was a surgical one. Surgical and medical treatment of ovarian endometriosis. Symptomatic patient with future fertility aspirations, surgical and medical treatment, with an emphasis on impact of surgery on the ovarian reserve. So when we offer surgical, we have to discuss the impact of surgery on ovarian reserve. There is no evidence surgery would result in better future fertility in women who have not tried for pregnancy yet. Means there is no evidence that a woman who has not tried for pregnancy means we are not aware of her fertility status and we perform surgery. Is it going to help her or not? We do not have any evidence. Though increased spontaneous pregnancy rates following surgery apply only to women with a history of infertility. So there is increased spontaneous rate after surgery in a women with a known fertility. But if we have no idea, then we cannot comment. Means a woman who doesn't have fertility concern by any chance and we perform surgery, probably there is no role per se. Symptomatic patients with future fertility aspirations. So this is second part of this. Preoperative antimalarial hormone levels compare with postoperative AMH. Biomarker to benchmark ovarian reserve after surgery. AMH to predict reduced or diminished post-operative ovarian reserve should be evaluated before surgery. It means AMH should evaluate before surgery. Why? So we can compare pre-operative with post-operative. Median pre-operative AMH level is 3.9 nanogram per ml. There is significantly decrease or decline, that is 1.5 nanogram ml from 3.1 to 1.5 nanogram per ml within 1 to 9 months post-operatively. Reduction of serum AMH level is more in women with bilateral endometriomas compared with those with unilateral. Okay, so serum AMH level, obviously, if you think it logically, you are operating ovaries on both sides. Probably some ovarian tissue damage on both sides. So definitely reduction is comparatively more than unilateral. When diagnosed with iatrogenic poor ovarian response, following laparoscopic cystectomy, for endometriomas exhibit significantly lower pregnancy and live birth rates compared with those primary poor ovarian response. Means that a patient who has primary poor ovarian response, and we compare that patient with a patient who had a surgery and after that she had poor ovarian response, means one patient with primary poor ovarian response and one patient post surgery poor ovarian response. So live birth rate and the pregnancy is lower post surgery poor ovarian response. Means who has primary poor ovarian response, she has more chances of pregnancy and live birth comparative to iatrogenic poor ovarian response. This is a very important SPT question because patient may ask this. Symptomatic patient with future fertility aspiration still continues. Biphasic pattern. This is the pattern which we notice in AMH post-surgery. Decrease 1 month after surgery, then a gradual increase at 3 to 6 months, and complete recovery by 12 months. Persistent reduction only in bilateral endometrioma. So this increase normally we notice in unilateral endometrioma because there is persistent reduction in bilateral endometrioma. Still, we are continuing with symptomatic patient with future fertility concern. Fertility preservation should be offered prior to cystectomy. Compromise ovarian reserve or significant risk of premature ovarian insufficiency. Patient with bilateral ovarian endometriomas. Those with a history of previous unilateral endometriomas, cystectomy with subsequent contralateral recurrence. So, before cystectomy, where we offer fertility preservation, this can be a very important SD and SPT question both. Where we offer fertility preservation before cystectomy, when there is compromised ovarian reserve or a significant risk of premature ovarian insufficiency, or in a patient with bilateral ovarian endometriomas, or those who are coming with a history of previous unilateral endometrioma already operated and now again subsequent contralateral recurrence. Symptomatic with future fertility concern still continuing. This is the longest topic in complete talk. Symptomatic patient with future fertility concerns. For post-pubertal women, fertility preservation techniques include oocyte or embryo cryopreservation, following controlled ovarian stimulation to facilitate subsequent IVF with embryo transfer. So, for post-pubertal women, choice is oocyte or embryo cryopreservation. As we have read, that ovarian tissue preservation can be done in a patient or in a woman or in a girl who has not started menstruating. Disadvantages associated, just a minute. Disadvantage associated with pre-cystectomy fertility preservation means every surgery has certain advantages and disadvantages. So if we perform fertility conservation or preservation before cystectomy, it also has certain disadvantages like postponement of surgery. Postponement of surgery is exactly as like postponement of IVF, which we have discussed earlier. Risk of visceral injury during oocyte retrieval. Pelvic infection arising from inadvertent cyst rupture. Because cyst is there, so there is a risk of inadvertent injury. Risk of ovarian torsion secondary to controlled ovarian stimulation, because after stimulation there will be risk of ovarian hyperstimulation syndrome or formation of multiple follicle, which will further increase the size of ovaries, and there will be more chances of ovarian torsion. There is no NHS funding for fertility preservation for non-cancerous condition. As we have read in oocyte preservation, there is social freezing. Social freezing, and there are certain conditions like cancerous patient where NHS offer, but other social freezing they do not offer. Now, this is third topic, symptomatic women without current fertility aspiration. So far, we have discussed symptomatic women with fertility, symptomatic women with future fertility concern, and now symptomatic women without current fertility aspiration. So, symptomatic with fertility, symptomatic with future fertility, and symptomatic without current fertility aspirations. Ultrasound findings where we find endometrioma. It is normally associated with pelvic adhesions, that is 73%, endometriotic implants, and adenomyosis around 85%, and deep endometriosis. So endometrial ultrasound, if you find endometrioma, there is possibility that while performing surgery, you may find pelvic adhesions, endometriotic implants, adenomyosis, and deep endometriosis. For symptomatic patient, definitely surgical treatment is an option for treating pain. Why? Because with surgery, there is some compromise with fertility, which is not a concern in her case. So symptomatic patient without fertility concern, surgical treatment is an option. And what is that option? That is laparoscopy, ovarian cystectomy. And how does it help? Comprehensive evaluation and treatment of pelvis and peritoneal cavity. It gives us comprehensive evaluation and treatment of pelvis and peritoneal cavity. What we do? Assessment and the management of superficial and deep endometriosis, tubal abnormalities, again assessment and the management, and the pelvic adhesions. So surgical treatment is an option in a symptomatic patient who doesn't have any fertility aspirations. In laparoscopy, it helps in evaluation and the treatment of pelvis and the peritoneal cavity. Evaluation and treatment of pelvis and peritoneal cavity. What we do? Assessment and management of superficial, deep endometriosis, tubal abnormalities, and pelvic adhesions. Symptomatic patient without current fertility concern, it continues. What we do in surgical treatment or laparoscopic ovarian cystectomy. Complete excision of endometriotic lesions. Complete excision of endometriotic lesions. Restoration of pelvic anatomy. Very important. Restoration of pelvic anatomy. Preserving long-term reproductive potential, obviously. Definitive diagnosis by histopathology and exclusion of ovarian malignancy. So, when we offer surgical treatment in symptomatic patient who doesn't have any current fertility concern, there is complete excision of lesion, restoration of pelvic anatomy, and long-term reproductive preservation and definitive diagnosis by HPV and exclusion of ovarian malignancy. Symptomatic patient with current same medical management for pain or post-operative hormonal treatment to prevent recurrence can be an option. Okay, this also can be an option. Medical management for pain or post-operative hormonal treatment. Now, asymptomatic. So far, we have discussed symptomatic, right? Symptomatic. Now we are discussing asymptomatic. Patient is asymptomatic, came for fertility treatment. So you have done ultrasound and you came to know that she has endometrioma, but she doesn't have any symptoms. When there is either no clear indication for ART, like young patient with a short history of infertility, or patient doesn't agree to it, then conservative management should be offered because patient is asymptomatic, right? So when there is no indication for ART, like young patient with short history of infertility or patient doesn't agree to it, then we have to offer conservative. Young women with regular cycles should be counseled towards natural conception. A young woman who is having regular cycle and incidentally diagnosed with endometrioma and has infertility, you should encourage her for natural conception. If clear indication of ART like some severe male factor or bilateral tubal damage, then directly offer ART. So a symptomatic patient with infertility, we do not offer surgery, especially if there is a severe male factor or bilateral tubal damage. You should directly go for ART. And offering IVF, what is the advantage of offering IVF? That is to optimize time to pregnancy, minimize risk associated with surgery, and reduce associated patient cost. This is very important. So now patient is asymptomatic coming with infertility. So if there is no clear-cut indication, you should offer her conservative management and you should offer her for natural conception. If there is no indication for ART, so here first you offer her or encourage her for natural conception unless there is an there is a clear cut indication for ART, then you are encouraging her for conservative management and natural conception. Now coming to if she has clear cut indication like semen analysis is not good or HSG is showing that there is bilateral tubal damage. And what is the advantage of offering IVF on time? These are the advantages. That risk reduces, which is associated with surgery. Patient cost definitely reduces because they do not offer NHS funding for all the patients. Now, what is endometrial fertility index? It's a very important index. This is an index, this is a tool to estimate probability of natural conception following surgical intervention for endometrioma. This is a clinical tool to estimate the probability of natural conception following surgical intervention for endometrioma. A patient you have operated upon for endometrioma, after seeing her inside condition, keeping her age, history in mind, you make a calculation. We call it as endometrial fertility index, and that is a tool which is give us estimation the probability of natural conception. What are her chances of conception naturally after surgery? High post-operative EFI score means more chances of spontaneous conception and live birth rate. Scoring is between 0 to 10. 5 to 10 means more chances of spontaneous conception, and we refer to fertility clinic only after 2 years if she doesn't conceive. When it is 0 to 4, we should refer to her to IVF for ART, but there it is given in a year. Probably immediately still count in a year there. AFI can be reliably and reproducibly measured non-invasively with the use of ultrasound. Normally, AFI we calculate after performing surgery because we have certain calculating points. But one can do with the use of ultrasound, that is a useful guide that patients towards surgery or fertility treatment. If you get a good ultrasound and you can calculate, so you will be able to reliably and reproducibly measure without any invasion what is useful for patient like surgery or fertility treatment, exactly as we do after surgery. If we calculate 0 to 10 and she falls in category from 5 to 10 after ultrasound, we can offer her natural conception. But if she is falling between 0 to 4, probably we will offer her for the fertility treatment. Or if she is falling between 5 to 10, probably surgery will be a better option. But if she is falling between 0 to 4, fertility treatment will be a better option for her. If we do after ultrasound and she is falling between this, fertility treatment, offering her ART would be a better option. Asymptomatic patient with future fertility concern. So far, we have read asymptomatic patient with fertility concern now means current fertility concern. She wants to conceive now. Now we are discussing a patient who is coming with future fertility concern, and by chance, incidentally, she is diagnosed with endometrioma. First line treatment is conservative management and checking the size of endometrioma at regular interval, right? And we have to explain her long-term effect of endometriomas. Ovarian cryopreservation prior to surgery, just like symptomatic patient, we can offer her. So first line treatment is always conservative. We have to check the size regularly and we have to inform her about the long-term effect of endometrioma. Simultaneously, cryopreservation can be offered exactly as we offer for symptomatic patients. Asymptomatic patient without future fertility concern. This was future fertility concern, which we have just discussed. Now, asymptomatic patient without. So this was with future fertility concern, and this is without future fertility concern. So we have to give her, or we can give her all three options: conservative, medical, and surgical, with pros and cons. Asymptomatic patient without fertility concern, as we discussed, we can offer her conservative, medical, and surgical. But we need to inform patient this as well while informing about her options, all treatment options which we have offered her. We have to inform her this as well, that there is a rare risk of spontaneous rupture. There is a very rare risk of spontaneous rupture. If she comes with this fear and she asks for surgery only because of this fear, so you have to inform her that there is rare risk. In long-term conservative management of endometrioma, rare factor of ovarian cancer should be aware of, right? Because we can miss this diagnosis, especially when the size is more than 9 centimeter post-menopausal and with presence of solid component in endometrium. So when we offer her our treatment options, because she doesn't have any fertility concern, because she's not asymptomatic, so probably presently she doesn't have any concern at all, and we come to know about this endometrioma incidentally. So it's your duty. You are not going to just send patient, okay, go home. You do not have any complaint, you do not have any fertility concern, so nothing is required. No, you have to inform her that there is a rare risk of rupture, and in long-term conservative, when we are just observing the size, there is a possibility of rare risk of ovarian cancer, which we can miss, especially if size is more than 9 centimeter, patient is post-menopausal, and there is solid component. Here, one thing very important to remember as clinician, women who is above 45 or above endometrioma, like women 45 or above with endometrioma containing blood clot. So a woman whose age is 45 or above, so a woman whose age is 45 or above and is having endometrioma and that is containing blood clot that can mimic solid component. So you need to take a help of a good radiologist here to differentiate between whether it's a blood clot or a component, solid component. Again, it's a very important SD point. Thank you very much. This is all about New Talk, October 24, endometrioma and the treatment. My next video will be about wall or surgical options we have. Take good care of, keep studying. Do like, share, and subscribe if you like my video. And thanks for taking your time to watch my video. Bye bye. Good night. Take care.